Welcome everyone to the June 2021 Music Prostate Cancer Skills Workshop. For those outside the collaborative who are joining us, Music is the Michigan Urologic Surgery Improvement Collaborative. We're a group of practices, institutions, and providers who have partnered with the support of Blue Cross and focus on quality improvement activities in urology. Music currently consists of 46 practices with more than 260 urologists, which represents more than 90% of practicing providers in the state. Music also maintains a robust prostate cancer registry with more than 85,000 biopsies and 16,000 prostatectomy patients, of which 20% of men harbor high-risk disease. And it's this group that we'll focus on today. We are joined by an internationally renowned group of faculty. I would like to thank Drs. Matt Cooperberg and Dr. Tom Hope from the University of California, San Francisco, and Dr. Des from the University of Michigan as our guest speakers. And I also welcome back Dr. Semerjian and Peabody, who helped lead the prostate cancer initiatives in music. Today, we will start with a review of the clinical application of PSMA PET imaging from Dr. Cooperberg, followed by an update on the status of PSMA PET in the US by Dr. Hope. Then Dr. Semerjian will share some important insights from our own experience in the state of Michigan with high-risk prostate cancer patients. And finally, this will be followed by a discussion on the surgical management of high-risk patients by Dr. Peabody and radiation therapy by Dr. Des. Thank you again for joining us, and I'll turn it over to Dr. Cooperberg. Thank you.
Thanks a lot, Arvind. It's really a pleasure to be here and an honor. I've watched the work going on from the music registry for years, and it's really a model for a lot of what we're trying to do in quality improvement across the country. It's been a model for the work we're doing at the AUA in terms of Aqua. And frankly, most of us that don't live in Michigan are envious of your infrastructure and all that you've accomplished. So it's really a pleasure to be with you all today and to give an update on what is going on in imaging for advanced prostate cancer in the very exciting space of PSMA PET. These are my disclosures, none of which are particularly relevant today. As of very recently, when I would give these talks, we'd say the standard of care really has remained CT or MRI for pelvic imaging and bone scan for distant disease, with the only PET tracers being approved for use really being limited to choline and fluciclovine or Aximen. Now, of course, the world changed quite suddenly in December of 2020, when finally, after a couple of years of advocacy, the FDA approved the use of gallium PSMA PET for men with prostate cancer in the US. Now, to step back for a minute, we need to recognize that PSMA PET, like MRI, is playing in the increasingly crowded space of prostate cancer biomarkers, for which we honestly now have more markers than we really know what to do with. And just like MRI has its role at multiple decision points along the patient journey, from should we get screened all the way up to how to manage advanced disease, PET-CT likewise is being investigated in both the pre and post primary treatment settings, as well as being used in advanced disease. And this is really just all coming at a time when we're still trying to figure out how to right size imaging for men with prostate cancer. For many, many years, the story in imaging was really about overusing things like bone scan. And here, I think we have finally made major strides. This is a look in the national Aqua data at the proportion of practices who are meeting measures in terms of not overusing bone scan. So now we are really changing the playing field in terms of high-risk disease with these new tracers. This slide summarizes the existing tracers that are out there. And just to highlight a few things briefly, FDG PET really has very little role in prostate cancer, with the exception of some biologic variants in advanced disease with CRPC. Sodium fluoride PET effectively is a more sensitive and less specific bone scan, and is probably going to fall by the wayside in the near future with the advent of later tests. Choline, as I mentioned, has been approved, but has had very limited availability in the US. Fluciclovine is, I think, the current most widely available agent for imaging both soft tissue and bone. This is Aximen. And then, of course, the gallium PSMA. And you can see the pros and cons of each of these here. And these are increasing in terms of sensitivity. What's the likelihood of finding something after primary treatment at varying levels of PSA? And I'll show more details on this a little bit later. But the bottom line is PSMA PET is by far the most sensitive test that we have available now for finding prostate cancer anywhere in the body. Very briefly on whether PSMA should have a role at diagnosis before initial treatment for local staging. And there's been relatively little work here, although there's some very interesting studies ongoing at UCLA and elsewhere, which suggests that PSMA might be at least as good as multiparametric MRI in terms of identifying local disease, but I would say it's still relatively early. Now, in terms of using PSMA PET for staging prostate cancer, the conversation here really needs to be couched in terms of my title slide of stage migration and what's known as the Will Rogers phenomenon. I think many are familiar with this term at this point in urologic oncology and other areas of oncology. In case you're not, the Will Rogers phenomenon is named after Will Rogers, the comic from the early 20th century, who had this famous line that when the Okies left Oklahoma during the Dust Bowl and moved to California, they raised the average intelligence of both states, which of course is a ding at the Okies, but an even bigger ding at the average intelligence in California. Now, I might argue that subsequent voting trends and COVID vaccination rates have made California kind of look okay in the end relative to Oklahoma. But nonetheless, this is a really important phenomenon in urologic oncology and again, elsewhere in oncology. And I do want to spend a minute to just give an illustration of what this does, because it's all about reclassifying men from one bucket to another. And we've seen this with things like Gleason grade shift, with with earlier use of MRI, anything where we are finding disease earlier, we need to think about what we are doing to classification of M0 versus M1. So these tables here are purely hypothetical. They show the same 100 men hypothetically undergoing a bone scan or a PET scan. And in both cases here, we're assuming that half the men actually have metastatic disease, half do not, okay? And again, hypothetical numbers here. Let's assume that on bone scan, we can find 8 METs. These are the true positives. Bone scan is going to miss a lot of disease. These are the false negatives. There are going to be some false positives on bone scan and many true negatives. Now, if we run the same men through a PSMA PET, we're going to find more true positives, fewer false negatives. There will be probably a little more in terms of false positives, because again, we're looking at both soft tissue and bone. That's an assumption here, and still a large number of true negatives. Well, what does this do to our calculations? So the sensitivity and specificity, sensitivity is much better for a PET compared to bone scan. Specificity is almost as good. The positive predictive value looks much better. The negative predictive value is also much better. But don't forget, we haven't changed anybody's biology. All we've done is reclassify men from M0, quote unquote, to M1. And in the bone scan group, there's only 10 men in the so-called M1 group who we've found by bone scan. These have a relatively high burden of disease. They're going to fail quickly. The 90 M0 patients, there's many false negatives in here. So these will have kind of a mixed bag in terms of outcomes. If we then run PET CT instead, well, we've got M1 patients that have a lower burden of disease on average, so they will do better than the patients who are M1 by bone scan. Conversely, the M0s have been culled of the false negative M0s, so they're actually going to do better than the M0 group in the bone scan era as well. So both the M1s look like they'll do better. Both the M1s and M0s look like they will do better in the setting of PSMA PET compared to bone scan, even though, again, we have not changed a single patient's biologic status or clinical status. This is the Will Rogers phenomenon. The average intelligence of both states go up. The average outcomes for both groups, M0 and M1, look better. But all we're doing is shifting populations from M0 to M1. And this started even before the advent of PSMA PET, partly because until we had all the novel treatments available for metastatic prostate cancer, therapeutic nihilism largely prevailed, and there wasn't a lot of incentive to find aggressive disease early. And there was a well-known example of a drug called zibotentan, an endothelin antagonist, which never made it to clinical practice. But in the large trial where they were accruing supposedly M0 CRPC patients, 45% of the patients accrued across the world failed screening. And the most common reason for this is that they had M1 disease on bone scan. Nobody had even bothered to get a bone scan, let alone advanced imaging, because we didn't have much to do for it. Well, now we've got lots of drugs for M1 disease specifically, so we have a reason to find it, and we've got better imaging. Now, I think there's very little argument that PSMA is the best of the tracers available to us today. The sensitivity varies quite a bit from tracer to tracer, but I think it's increasingly clear that PSMA is better than all the others available, including fluciclovine, in terms of identifying burden of disease. This is a fairly extreme example of PSMA PET showing much more disease than the fluciclovine, but you can look at these over multiple studies now. This is a recent, relatively recent review looking at sensitivity for showing disease, assuming true positive disease at varying PSA thresholds, less than 1, 1 to 2, greater than 2, for the different tracers here. And at all thresholds, PSMA PET, the red bars here, is more sensitive than either choline or FACBC, which is, again, fluciclovine. Now, this is in terms of distant staging. That was for nodal staging. Same thing has been shown for distant staging. In fact, in terms of specificity, some studies have shown higher false positive rates for fluciclovine than for PSMA PET, particularly when it comes to the inguinal lymph nodes. Now, it's important to recognize that the different tracers do not always co-localize, which is kind of interesting. This is a look at sodium fluoride versus PSMA within a single patient. They ran both PETs simultaneously. And while it looks at a high level that the overlay is relatively the same here for this pubic bone met, for example, when they drill down, there actually is some interesting kind of lack of registration, probably reflecting variant biology or bone response to the tumor rather than actually misregistration of the scans. And it's also known at the histologic level that PSMA expression can vary quite a bit within a given patient with multiple tumors and sometimes even within a given lesion. We've also shown recently at UCSF that PSMA expression at the genetic level actually correlates reasonably closely with disease risk. This is PSMA expression, again, at the RNA level with genomic risk as reflected by the Decipher score here. And we see this much more for PSMA than for the fluciclovine transporters. That's the LAT and ASCT genes, which are the ones associated with fluciclovine uptake. The best study here comes from UCSF and UCLA, where a head-to-head study was actually performed for a substantial cohort of men running, again, both fluciclovine and PSMA PET. And for every question, overall sensitivity, lymph nodes, and all the various extra prostatic sites, PSMA was more sensitive than fluciclovine. The only exception was for local restaging of the prostate bed, which was not a statistically significant difference. So again, not much argument that PSMA PET is the best of the available options. But then the question is, well, how good is it really? And the answer really is, it depends. This is, by design, a busy slide because the literature really is quite rich at this point. There's lots of studies from Europe and Australia over many years now. But if we really want to get to the question, what is the true false positive, false negative rate? It's actually pretty tough to nail that down because we typically do not have gold standard pathologic confirmation in the vast majority of the studies in this meta-analysis here. So, you can see good sensitivity at all the different sites, the prostate bed, pelvic lymph nodes, extra pelvic lymph nodes, bone, and viscera. The sensitivities here vary by PSA. But again, it's a little bit hard to answer the question precisely, what is the false positive rate? Now, there are attempts at standardization of the reads now, kind of getting to the same concept as PIRADS. This is one called ePSMA. There's another one called PROMISE. And I think this is going to be an important area for research as PSMA leaves the academic centers and gets out into community practice, which is going to happen very soon, as my colleague Tom Hope is going to discuss in the next talk. It's going to be very important that we're all speaking the same language and really using a standardized approach to reporting these scans so that hopefully we can avoid some of the major problems with inter-observer variability and unreliability that we are seeing with PIRADS and MRI. So getting to this question again of what we do with this Will Rogers phenomenon and how we use these scans in 2021 as they're about to hit the general market is, what do these do to our clinical management? Because again, that's the key question, right? We should never order any test in medicine that is not going to change our management. So how do we react to a positive PSMA PET in the setting where a bone scan would have been negative or a CAT scan would have been negative? So of course we define oligometastatic prostate cancer, for example, as 5 or fewer metastases on a technetium bone scan. So if the bone scan is null, but there's 8 lesions on a PSMA PET, well, is that oligometastatic? or not? And I would argue the answer is we really don't know. So as just one example among many here, you have all likely heard about the STAMPEDE trial subset analysis. This was arm H of STAMPEDE, the UK trial, which has randomized men to many different treatment combinations. The relevant arm here was men who were newly diagnosed with M1 disease by bone scan, who were treated with lifetime ADT plus or minus docetaxel, and were randomized to get radiation to the prostate or not. And what they found here was a signal toward improved failure-free survival, but only for those men who had oligometastatic disease. For those with higher burden disease, there was no difference, which is what you see here in the forest plot. The favoring radiotherapy arm is metastatic disease by bone scan. So what do we do with the example I just mentioned, who has a negative bone scan but has more than 5 lesions by PSMA PET? Well, I think most would argue the trial was done based on bone scan. If it's a negative bone scan, you would offer that patient radiation therapy if you believe this subset analysis. But then we get into the somewhat perverse situation of taking men who clearly have metastatic disease, oligo or widely disseminated, on PSMA PET, and then put them through a bone scan just to see if we can slot them into this subgroup for this purposes of applying this trial result. And this is really an unsolved challenge, which I don't think anybody in the field has really addressed yet. Because the fact is, every single trial that has focused over the last 20 years on quote unquote M0 versus M1 prostate cancer have defined those buckets, as well as the oligo versus polymetastatic buckets, based on technician bone scan. So, what do we now do with these trials? Do we have to repeat them all? How can we extrapolate into the PSMA era? This is really an area for key future research. And likewise, what do we do with primary therapy? If we see a man with a negative bone scan, but one spot in a bone somewhere, is he eligible for local therapy? Is he eligible for radiation therapy based on STAMPEDE? Is he still eligible for prostatectomy? These are, I think, the questions that we're really grappling with at this point. And again, anybody that says they have the answers here, I think doesn't know the complexities of the literature. And then it raises the following question: should we be going after these lesions with subsequent treatment? Should we be doing salvage lymph node dissections? Should we be doing SABR, stereotactic body radiation therapy? And again, I don't think we really know yet. There's a reasonably good meta-analysis done of 14 studies, mostly small, looking at men who did undergo salvage node dissection. The field sensitivity for the PSMA PET was reasonably good, positive predictive value, also relatively good, but ultimately the vast majority of these men do recur. And the same issues sort of apply in most of the the SABR trials as well, the body radiation trials. And I would give a huge hat tip here to my colleague, Declan Murphy in Australia, who's done a lot of PSMA work and has some great acronyms for us all to remember here, which is that PSMA really stands for the pretty shiny metastases to attack. SABR, we can strike at the bright regions. SLND, salvage node dissection, of course, surgeons love no data. And, I think this is, of course, all tongue in cheek, but we really do need to be very, very aware of what the data do and do not tell us in 2021, and where our challenges are in terms of applying an older literature in what is a new contemporary practice. It is great to be able to say that RCTs are coming, and there are actually now multiple RCTs underway. None of these has been reported yet, but this is one trial, for example, out of UCLA, which is randomizing men to conventional imaging versus PSMA PET, and then directing radiation therapy based on either standard imaging or PSMA PET, and looking at the success rates for, this is salvage radiation therapy at 5 years. There's a larger multi-center trial, international trial, also kicking off now, which again randomizes men to standard imaging versus PSMA PET. Again, looking at progression-free survival at 5 years. These are the trials that we need to see to validate the test itself, although it's still not going to get us to the point of knowing whether or not we can apply results of trials like STAMPEDE from the bone scan era to the PSMA era. And now everything we've talked about so far is really focused on gallium PSMA, which is the one that's now approved by the FDA. But there are many other PSMA PET tracers which are coming very soon. I think Tom Hope is going to talk in the next talk about the time course for many of these, but at least one of them, at least the PYL agent, should be hitting the marketplace relatively soon. And this will have the advantage that it can be shipped to a local radiation center as opposed to the requirement for generation of the isotope on site using a cyclotron, which is the requirement for gallium PSA and will always limit its broad dissemination. So PYL will be more available in community practice once it's actually here. And there's a number of other tracers which are coming in the next 1 to 2 years, basically, many of which look relatively similar in terms of their performance characteristics. So there will be more options for patients and for imaging colleagues to increase the access to this to these scans, because for the time being, it is really still just UCSF and UCLA, although that's going to change over the next few months. And I would also make the point that PET has room to be even more functional. PSMA imaging is really looking at disease aggressiveness and anatomy, but there are other tracers much more upstream in terms of development, which can help us look not just at anatomic extent of the tumor, but actually its function as well, and can get us beyond virtual biopsy, even into virtual metabolomics non-invasively. And this will be a very, very exciting space to watch. Finally, I'm sure many have heard of the coming future of theranostics, by which a man with very widespread disease evident on a gallium PSMA scan is then given an agent like lutetium tagged PSMA or actinium tagged PSMA, which then carries local radiation therapy to the sites of metastasis only. And again, this is not a perfect scan. Sorry, this is not necessarily a representative scan, but it is exactly the sort of pictures that's driving a ton of excitement here in the field. So to sum up, imaging tests are biomarkers, just like the liquid and tissue-based markers, and they do need to be evaluated in light of all the available clinical information to prove their efficacy. PET-CT, PSMA PET, as the clear leader here, is completely changing what we understand about prostate cancer biology and patterns of spread, and it's driving a stage migration, the likes of which we have not seen in prostate cancer for decades. And I would argue that we still don't really know what to do with the results. The theranostics are very promising, and the other emerging field here is going to be intraoperative imaging using PSMA-targeted tracers. So the future is extremely exciting, and the trials are now underway that will help guide what we actually do with these results. So with that, I thank you for your attention. It is a great pleasure to now pass on the podium to my colleague, Tom Hope, who I think it's safe to say deserves more credit than any other individual for bringing PSMA PET imaging to real-world practice for men with prostate cancer across the country. Thanks again, and I hope to see you all in person somewhere sometime soon.
Well, thanks for the introduction, Matt. And it's been wonderful working with you over the past, 8 years now at UCSF and also the San Francisco VA. And I'm excited here to talk about the current status of PSMA PET in the United States. So here are my disclosures, maybe some of which are relevant to this discussion. So we're going to be talking about PSMA, right, which stands for prostate-specific membrane antigen. It's a transmembrane protein that's overexpressed on prostate cancer cells. Amusingly enough, it's actually not specific to prostate cancer. It's also expressed on other cancers like renal cell carcinoma, as well as things like thyroid cancer or ovarian cancer. But it really is most highly expressed in prostate cancer, and it's very specific in the setting of a man who has prostate cancer for metastatic disease. Now, there are a lot of PSMA PET radio tracers out there, and here are 5 of them: PSMA 1007, RH-PSMA7, DCF-PYL, PSMA11, PSMA617. It's sort of a word jumble in the end. But if you look at them, they all share a really very similar binding motif. It looks like a urea molecule, and it binds to the PSMA transmembrane protein, and what gives the specificity of these molecules for prostate cancer. Now, I think of these all as a class. but that binding molecule is attached to a chelator or a chain, and that different molecule is attached to the urea motif is going to result in a variation in biodistribution. So here's 4 different compounds, and you can see, for example, PSMA 11 over here on the left, and DCF-PYL actually have a very, very similar biodistribution and really behave very similarly. PSMA 1007 is somewhat unique in that it has much more liver clearance, as you can see here, and that allows you to see local disease maybe better because there's not a lot of activity in the bladder. I also threw up CTT 1057. This is the compound made at UCSF, and this is the one compound out there which doesn't actually use that same urea motif for binding to PSMA. But overall, think of these as a class functioning very similarly. And they actually function very, very well. So here is a patient where you can see a humeral metastasis in the left internal iliac nodal metastasis. And you can see both osseous and soft tissue disease at the same time. And we're getting really close to the time where we're going to no longer be getting CTs and MRs and bone scans in stage patients with prostate cancer. Instead, now we can do a single imaging study to localize disease in the bones and in the soft tissues. Now, at UCSF and UCLA, we ran some prospective trials evaluating gallium-68 PSMA 11. And in our trials, we had 277 patients who underwent prostatectomy. We had a sensitivity at the initial staging for nodal metastases compared to prostatectomy of 40%, which was actually lower than we had anticipated. But I actually think this is a real number. So PSMA PET doesn't see all nodal disease, but it does see the larger lesions for sure. And it certainly outperforms conventional imaging, which would have a much, much lower sensitivity than this. I think the take-home point, obviously, is that if you're going to use PSMA PET in initial staging, probably, at least at this point, I wouldn't forego a standard salvage lymphadenectomy if the PSMA PET is negative, because a negative predictive value is not good enough to do that. We also ran trials in biochemical recurrence. So here is our JAM oncology data looking at gallium-68 PSMA PET stratified by PSA level. And obviously, as your PSA goes up, that is going to result in a higher sensitivity or detection rate for prostate cancer. Overall, it has a very good positive predictive value for prostate cancer, although there are some false positives, mostly in ribs and regions like that. Some of the false positives in this paper were actually local recurrences where it's not really clear what is recurrent disease or not on pathology. One of the important things with PSMA PET is that interpretation is actually much easier. Our interreader variability, or Cohen's kappa, is very high, pretty much all in the 0.7 range based on the region where the analysis is done in this paper. And so the interpretation of this is very good. And you'll see when we get to the end, comparing this to fluciclovine, this is actually really one of the main benefits of PSMA PET, obviously, in addition to its increased sensitivity. Now, in December of last year, we actually obtained FDA approval at UCSF and UCLA for gallium-68 PSMA 11. And I think it's important to note the indication on the FDA label. So it's indicated both in patients who had suspected metastasis who are candidates for initial definitive therapy, so upfront at initial staging, and also in patients with suspected recurrence based on elevated serum PSA level. So it's both in biochemical recurrence and initial staging. And this is the first radiotracer that was approved for initial staging in patients with prostate cancer. Now, that's wonderful, but gallium-68 is problematic, right? It has a 68-minute half-life. It's generator produced. This little silver thing here is the gallium generator, and you can only make 2 to 3 doses per synthesis. And so at our institution, we do 3 syntheses a day, and we, in essence, image 6 patients a day with this. And it's not nearly enough production to actually image all of the patients who have prostate cancer out there. And we obviously have a backlog for this. And so there's a need for a radiotracer that can be more widely distributed. And that's obviously where DCF-PYL comes in. So fluorine-18 DCF-PYL was studied in the Osprey and Condor trials. The Osprey trial was sort of the initial trial, and this had 2 cohorts, one in the initial staging and one at time of biochemical recurrence. The initial staging cohort actually mirrored nearly perfectly our data at UCSF and UCLA, again, with a sensitivity of 0.4, very similar number of patients. And I think it really demonstrates that this is a class, right? These imaging agents function very, very similar between DCF-PYL and gallium-68 PSMA 11. And the data from each one of the 2 drugs should be applied to the other to allow us to inform how to use that drug. Cohort B in the OSPREY trial was done in biochemical recurrence, but interestingly, when they designed this trial, they actually required patients to have biopsyable disease on conventional imaging prior to enrollment, which is sort of irrelevant because those patients obviously are going to have much higher PSA and positive conventional imaging. And so the median PSA in the cohort B was 11, which is obviously not where PSMA PET will play a significant role. So that is why the company went back and ran the Condor trial. And this was in patients with biochemical recurrence only, did not require biopsyable lesions. And the baseline PSA in that trial was 0.8, right? So much lower PSA, much more clinically relevant. And the FDA forced them to use, instead of positive predictive value, this term called correct localization rate. And the correct localization rate is very, very similar to a positive predictive value. And it's defined as a percent of patients with a 1-to-1 correspondence between the findings on PSMA by the central leaders and the composite standard of truth. And so it had a PPV or CLR in this data of 85 to 87% based on a 3-reader. So very, very similar data to what we have with gallium PSMA 11. And obviously that led to the approval of DCF-PYL, which is called Pylarify, which I think I will say only once in this talk. And the generic name is even harder to pronounce. So I think I might forever just keep continuing calling it DCF-PYL. And I think most people call it just PYL. And as you'll note, their indication label from the FDA approval is identical word for word for what we have with gallium-68 PSMA 11, which is very nice. So again, think of these drugs as a class, same ability to detect cancer, same indication levels. And this was approved. I'm taping this on the 28th, so it was approved yesterday. So nice timing for this. Now, just to remind ourselves, we have fluciclovine, which will soon be replaced by these 2 drugs. And although fluciclovine is much better than conventional imaging for localizing metastatic disease, it's not perfect. So here's an example of someone who had a right pelvic sidewall lymph node. On fluciclovine, you can clearly see it. It has a tumor to background ratio around 3, but on the PSMA PET, you can see the tumor to background ratio is actually more like 50, right? So it has a much higher tumor to background ratio, which really allows you to see this disease much more clearly. Now, in this case, that difference in uptake is really important in terms of diagnosis. So you can see in the fluciclovine in the right seminal vesicle there's a tumor to background ratio of less than 2, and it's very hard to actually appreciate that focus of uptake. But on the PSMA PET, you can clearly see with a much higher tumor to background ratio that lesion. And I would note that even though there's urinary activity in the bladder, it's still easier to see the recurrence on the PSMA PET. This was studied by Jeremy Calais out of UCLA in a head-to-head comparison of 50 patients after radical prostatectomy with a PSA less than 2. And you can see that there's a doubling in the detection rate of PSMA compared to fluciclovine. FACVC is sort of the DCF-PYL name of fluciclovine. But the one thing I think is really important is that if you look on this data, fluciclovine saw no sites of metastatic disease, right? And the lymph node rate was much higher, nearly 4 times higher with PSMA compared to fluciclovine. And fluciclovine only saw local recurrence pretty much. And as we know, in these patients who are post-prostatectomy with a low PSA, seeing local recurrence isn't actually that valuable because you're going to get salvage radiotherapy anyways. But really the most important thing is that it is much easier to read a PSMA PET. So in the 3 blinded readers who read the fluciclovine, the Cohen's kappa was 0.2, which is pretty poor, whereas with PSMA it was 0.67, very similar to what we found in our data in the JAMA Oncology paper. Now, obviously, all of these findings on PSMA PET have a huge impact on the management of patients with prostate cancer. So the location of the disease really is causing changes, and we need to understand better how to manage these patients based on PSMA PET findings, but that work has yet to be done. Insurance coverage with PSMA PET is definitely going to be a problem as we move forward. I think Medicare should not be much of an issue. Both PSMA 11 and DCF-PYL should be covered by the Medicare National Coverage Decision in oncology, but we are going to struggle with private insurance coverage, just like we did with fluciclovine, but we really hope to see the 2020 revisions of the NCCN guidelines to include both of these drugs to really help us convince private insurers to actually cover this drug. Now, just to go back to this slide, so we talked about the bottom 2, DCF-PYL and PSMA 11, which were both FDA approved, but both PSMA 1007 and RH-PSMA 7 are in phase 3 trials in the United States, so there's definitely more to come. And maybe more excitedly is this trial in the bottom right, the VISION trial with lutetium, PSMA 617, and the results will be reported on June 3rd, so in a week, and we'll see how that trial performed. So overall, thank you very much for listening. And I think the take-home points are PSMA PET is clearly a superior radiotracer to existing radiotracers out there for detecting prostate cancer. Gallium PSMA-11 and DCF-PYL are both FDA approved in the initial staging setting, as well as a time of biochemical recurrence. And with these two approvals, PSMA PET really should be widely available in the United States by the end of the year. And I'd like to thank a number of people at UCSF who've helped make our work on PSMA PET possible. It took a huge team effort to really do all of this work. I'd also like to thank my sponsors, including the Prostate Cancer Foundation and the NCI and NIH for supporting all of the work we've done over the years. It's really been very helpful to make this succeed. And thank you very much for listening. And I look forward to the discussion in our live Q&A.
Great. Well, those were great talks, and I feel like I learned a lot. We've actually been chatting already with Drs. Cooperberg and Dr. Hope, and I'm actually going to invite them in for the live discussion, and also Dr. Bob Dess, who's a radiation oncologist at the University of Michigan. And I welcome everybody in the chat to ask your questions within the chat, and then we'll ask them to our experts. I will say that this is your one opportunity to learn every single thing you can possibly know about PSMA PET with Dr. Hope, Dr. Cooperberg, and Dr. Dess here. So please take advantage of that. We do have one question that has come in to the chat so far. Are there any risk factors for a false positive or a false negative PSMA PET that can help us understand who we should optimize our patient selection or understand the findings of the study?
Yeah, that's a great question. And unfortunately, there's not a perfect answer to that. So I think the false negative is really in the setting of a biochemically recurrent patient, right? And, if you have a negative PSMA PET, you're a false negative by definition, right? So presumably a risk factor for that is a lower PSA. And obviously the patient level detection rate goes down as you have lower PSAs. So, I think the risk factor would be, as you image patients with lower and lower PSAs, just remember that you're more and more likely to have a negative study. Now, predicting who has a false positive is a different story. There are a bunch of false positives on PSMA PETs. Primarily, these are osseous or bone lesions. So things such as hemangiomas, enchondromas, aneurysmal bone cysts, fibrous dysplasia, a lot of these solitary rib lesions. If you happen to have one of them, I guess you have a very high pretest probability of having a false positive. But without knowing if someone had that, it'd be very difficult to tell a priori if they would have a high pretest probability for a false positive.
Gotcha.
Not every prostate cancer is all that bright in PSMA, and we are learning, just like PSMA, just as much as PSMA has taught us a huge amount about prostate cancer biology, there's also huge open areas still for learning. The two patients from our tumor report just today, Tom just told you about one of them, patient with vascular lesions in the bone, but the other one we discussed of mine was a guy who had high-risk disease, very high PSA after surgery, and all scans negative. The cancer is there, we're just not finding it. So the question is what it is about that biology that makes it relatively invisible.
Gotcha. Now, is there one of the other questions that have come through is there any utility for Axumin now that we have a PSMA PET approval? What happens to flucyclovine? Should we just go by bone scan and CT only until PSMA is kind of widely available down the street at our local hospital radiology imaging center?
So no, you shouldn't go back to CT and bone scan while you wait for PSMA, right? As long as if flucyclovine is what you have available, that it's a great imaging agent for the era it came in, and I'm sure in 10 years something will replace PSMA as the next generation of imaging agent comes along as well. Now, I think there's a debate to a certain extent if in the setting of maybe PSMA negative disease, is there a role for flucyclovine? And that certainly hasn't been evaluated well. People haven't really run very good trials looking at a cohort of PSMA negative patients. Can you actually localize the disease effectively? But generally head-to-head, PSMA outperforms flucyclovine quite dramatically in that setting for localizing metastatic disease. There will be little role for flucyclovine.
One of our outgoing chief residents, Chris Chu, did a nice study that just came out a few months ago, looking at gene expression in the primary tumor, correlating with different imaging findings. There is a subset of tumors which are ramped up in the immunoprocessing transport genes associated with fluciclovine uptake. So again, I mean, the biology's out there, but I don't think anybody could tell you upfront, well, this is a patient who should get fluciclovine instead of PSMA based on anything that we would have in the clinical chart.
And then Dr.
I don't know, Tom, if you want to mention the PSMA, the fluciclovine plus sodium fluoride dual protocol you've been running at our VA. I know it's hard to do outside of the VA setting, but
promising results.
It's a Band-Aid while we wait for PSMA at the VA. So fluciclovine doesn't see osseous lesions very well. It really detects the presence of bone lesions. So we actually we inject sodium fluoride about 45 minutes before we do the fluciclovine PET to try to get a chance to actually see the osseous mets, which you just don't see very well with fluciclovine PET. But no, I generally would not recommend that for most people. Okay. It works in a place where you don't have to worry about reimbursement.
Great, thank you. And so, in the state of Michigan, we're fortunate enough at the University of Michigan to have access to gallium-68 PSMA. So this is a question to Dr. Des. We both seem to tend to overlap with a lot of these salvage patients. There's not many people who feel compelled to take care of them apart from me and you. And so that's a challenging patient population to counsel and to manage. Do you have a preference for Axumin or PSMA in this setting, since you have access to both?
So to clarify for everybody, this is a continuation of a conversation that Dr. George and I were, and Dr. Cooperberg and Dr. Hope were having in the private chat. I think you're referring to the post radiation setting. Is that correct, Dr. George? Yeah. So we have been fortunate to have those tracers available. I think we have defaulted to the gallium-68. I think what we were commenting on the chat is that more than the tracer chosen, having some combination of MRI and a biopsy confirmation of that recurrence is really important before we even discuss going down a pathway of local salvage, of which there are many options which haven't been compared very effectively, frankly. But as Dr. Cooperberg said, it's a big, all have significant side effects, and confirming recurrence it cannot be done based off of PET alone, in my opinion. So
any time you have a PSMA lesion within the prostate for local recurrence post-radiation, we would sample it before deciding any salvage treatment. Are there inconclusive PSMA lesions, and what do you do with those? I know we had mentioned a little bit about standardization of interpretation. What should we be doing with these inconclusive or indeterminate PSMA lesions?
Okay, I'll try my best to answer that one. So I guess there's sort of two types of inconclusive lesions. One I would say would be local recurrences, where you have sort of subtle uptake and you're not sure what that is exactly. And I think that is where you would be recommending like a DCE MRI, maybe doing a biopsy, trying to characterize it. In that setting, it's easier to find a correlate in the sense of you can get a needle there pretty easily. The harder indeterminate ones are, again, these bone lesions, which sometimes are very hard to, like rib lesions are very hard to biopsy. I think we're coming to realize that the majority of these solitary rib lesions are actually just benign and should be not thought about as cancer. But it becomes a little bit of an art form because you're not going to ever really be able to definitively determine whether or not that's prostate cancer or not. Thankfully, it's not that common that you run into this issue, but it definitely happens. And, we see it all our tumor boards every week. We have at least one of these cases because when you're doing, we do 20 to 30 a week, one or two of them will end up having one of these indeterminate lesions that leads to a long discussion about what you should do. And I don't think there's a right answer to that question at this moment.
Okay, gotcha. Thank you. Now, what should be, if we had to choose indications, and I understand that we don't have clear, specific, this is what we don't know what the best patient population in every scenario is. What do the panel think would be reasonable indications in which to use it in the primary setting, in the primary staging setting? Like, I guess the question is, should we be opening it wide open because it's a much more sensitive test? Should we be including, favorable intermediate risk prostate cancer to be able to understand, I guess that's the ultimate question. Should we stick with what we kind of have as indications for CPT currently?
I think it's a really difficult question. Partly, well, there's two ways in which it's difficult. One is figuring out which patients are most likely to have visible metastatic disease, and I would argue they're, frankly, neither quote unquote favorable or unfavorable intermediate is a great way to make these decisions because there's so much heterogeneity within both of those categories. You can have one millimeter speck of 4+3 and wind up in the unfavorable box. Conversely, you could have a really high volume 3+4 with expanded solid cribriform subtype and high PSA density, be quote unquote favorable, but actually have a pretty significant risk of metastatic disease. So I think we really have to be careful about how we're doing risk stratification well beyond the current NCCN standard. So as far as, but beyond, even identifying the right band of risk in order to figure out who should get tested, then the question becomes, like I said in the talk, what do we do with the results? If we are using this to help, target or expand, let's say, a lymph node dissection template, or expand a radiation field to include an out of field bone lesion, for example, that's one thing. But if we're going to start ruling men out for local therapy on the premise that they now have metastatic, therefore incurable disease, I think that's a little bit difficult. And based on, again, decades of experience, knowing, including RCT evidence, stating that we do benefit these men. So the question is, which ones? There's the trial that Brian Chapin ran, which is now being taken up in SWOG, which is really accepting even men with polymetastatic disease, right? And I think we all kind of assume that the situation is something like it is in kidney cancer, where there's a benefit to cytoreduction, when it's a large primary and limited burden of systemic disease. But that's an assumption, and we don't have really much evidence at all to base that on, and we certainly don't have any evidence in the PSMA era. So if we're getting these scans to kind of help plan multimodal therapy, I think it makes sense, but it becomes a very delicate and I think often quite difficult counseling conversation with the patients when we find something on novel imaging that we did not find on standard imaging, because now we're trying to counsel in terms of what to do in the absence of much good prospective data, which is the luxury we usually have in prostate cancer, having those sorts of data.
So we're finding more sorry, Dr. Des, go ahead.
I would just say Dr. Cooperberg answered the more challenging of the questions, which is, I think, the burden of proof of removing local therapy is really on, that's a change from historical standards for which we've spent hundreds of millions of dollars and tens of thousands of patients in randomized trials establish what we do. Maybe I'll take a stab at a little bit easier of the question, whether you use CAPRA or our new staging system, or you have a pretty good idea of somebody who has pretty favorable outcomes. It's hard to argue that molecular imaging is going to make that much better. Those men tend to have very good outcomes with monotherapy of many types. And so I think in the higher risk patients, at least there may be some role for expanding of therapy, but I do question its benefit, upstream or downstream, however you want to view it, but more favorable risk patients.
Gotcha. So really, I think that sometimes I feel like this data ends up generating so many more questions down the line that we need to think about. We're like, great, we have this wonderful new test. We're going to find more prostate cancer, have more accurate staging. And then we're like, well, what do we do with this? And what does it have to do with, what will it ultimately do to patient outcomes? So certainly additional questions. What happens to MRI now? And what is the correlation between MRI findings and PSMA PET findings within the prostate? Everybody here is probably like, oh, he's definitely going to ask an MRI question. So there's my MRI question for the afternoon.
Well, I'll take a stab at that. So I think MRI stays just where it is. What I mean by that is MR is widely available. It's a heck of a lot cheaper than a PSMA PET. And it's not that much outperformed by a PSMA PET for localizing disease within the prostate. So when you're talking about an active surveillance patient or following patients over time, or more importantly, where to stick a needle, I feel like MRI now is relegated to telling urologists where to put the needle, right? And in that role, it functions very well. And I don't think, and not even when there's more data, I still think it'll sit in that space. And there's a really nice trial coming out of Australia that hopefully will get published by the end of this year, where they compared multi-parametric MRI to PSMA PET in the active surveillance population. And, I don't think there's going to be a big difference.
Great. And, sometimes I get consults for, somebody did an FDG PET and then they saw some finding in the prostate. What do I do with that?
You check a PSA. So FDG PET's very non-specific, nor is it sensitive, but you shouldn't have focal uptake in the prostate. So it's probably most likely prostatitis or something like that. So, we usually just say correlate with PSA. I guess depending on what's going on with the patient's risk factors, et cetera, you can consider biopsying it. I hate dictating that because I think whenever I make a recommendation in imaging, I always think, well, what am I trying to tell my referral to do? And in that setting, I'm not actually sure what I'm telling them to do, other than I see a finding, I don't want to be responsible for it.
We don't biopsy those. I get those once or twice a year too. And, I'll take that patient, somebody who has now been screened, which maybe he wasn't before. And we'll start with the elevated PSA kind of conversation, DRE, possibly MRI, secondary diagnostics, et cetera, et cetera. But we don't put needles in just because of FTG. Perfect.
That's great. Well, listen, this was a great discussion. I could really ask questions on this for an hour, but it's time for us to slightly change gears. So thank you, Drs. Cooperberg, Dr. Hope, and Dr. Des for joining us for this session and sharing your experience. Now, there are many unique aspects of high-risk prostate cancer that warrant discussion, and we'll touch on some of those in our next session here. So we'll lead off with Dr. Semerjian, who will be reviewing the outcomes of high-risk prostate cancer from the music registry within the state of Michigan. Again, thank you all to our panel for a great discussion, and thanks for your expertise.
Thank you.
Thank you for that great and very interesting discussion. I'm happy to present the music data on surgical treatment of high-risk prostate cancer patients. Music is a statewide collaborative in Michigan, founded in 2011 by Dr. David Miller and Dr. Jim Monty, with the goal of improving outcomes in prostate cancer and more recently, kidney stones and kidney masses. Over 260 urologists in 46 practices participate in music, which makes up about 90% of the urologists in the state. More than 100,000 cases are enrolled in music, including more than 16,000 radical prostatectomy cases. 57 peer-reviewed articles have been published. Music is unique in that it prospectively gathers data across practice type and setting to implement quality improvement initiatives. The focus of this talk is surgical outcomes in high-risk prostate cancer patients. The following data is taken from patients with any one of these features, or a combination of more than one. PSA greater than 20, Gleason score 8 or above, and clinical stage T38 or higher. This makes up about 20% of the 16,000 radical prostatectomy patients in music. This graph is looking at primary treatment selection in high-risk prostate cancer patients. There are 40 practices represented in this slide. Each bar represents one participating music practice. Within the collaborative, we see significant practice level variability. Rates of radical prostatectomy in high-risk men is shown in green. You can see that these range from 0% on the far left in practices 1 and 2, all the way to over 80% in practice 40. There's a similar pattern seen for radiation therapy as primary treatment, which is shown here in light blue. While we know that this decision is nuanced and specific to tumor and patient, the significant variability indicates that there's little consensus on how to treat these patients. Given this uncertainty, we're going to explore the music data on high-risk prostate cancer patients pertaining to oncologic outcomes followed by functional outcomes. Our data set encompasses over 16,000 radical prostatectomies from which our oncologic data is based, and 8,500 patient-reported outcomes on which quality of life data is based. Out of these, 20% are high-risk patients. This gives us a unique look at surgery as a primary treatment in a large group across the entire state in various practice types. Much can be learned about how to counsel our patients when choosing a treatment. First, we're going to look at oncologic outcomes for the men in music who have had prostatectomy for high-risk prostate cancer, including pathologic T-stage, margin status, biochemical recurrence, and ultimately the need for salvage radiation. Amongst men with high-risk cancer, more than 60% have locally advanced disease with pathologic T-stage, T3, or T4 at the time of prostatectomy. This compares with roughly 30% in the intermediate risk group and 15% in the low risk group. Of all high-risk patients who underwent surgery, Only about 40% are organ confined. This is an important factor in counseling and decision-making, as these men are more likely to need secondary treatment with radiation or ADT and less likely to be cured with surgery alone. Likewise, positive margin rates increase as risk category increases. In low and intermediate risk patients, positive margins occur in 25 to 30% of patients, but in high-risk patients, that number climbs to over 40%. These trends are similar to rates that have been reported in the literature. This could have important implications for intraoperative decisions, including to nerve spare or not. Functional outcomes can be adversely affected by taking a wider margin. And additionally, adjuvant or salvage radiation is highly likely to affect long-term functional outcomes. Although positive margins and pathologic staging are important, the most representative of the need for secondary therapy and long-term outcomes is biochemical failure. This graph shows the data from nearly 16,000 patients. Biochemical failure-free survival is defined as post-prostatectomy PSA of greater than 0.2. The green and blue lines represent biochemical failure over 5 years for low and intermediate risk disease. At 4 years, those numbers are 88% and 79% respectively for low and intermediate risk. There's a significant drop-off in biochemical failure-free survival in the high-risk group, shown here in red, within the first 3 to 6 months. This is likely indicative of persistence of PSA after prostatectomy and failure of the primary treatment. Additionally, this correlates to the higher T stage and margin status. Biochemical failure-free survival further declines to about 50% at 4 years, and this is important for selection of primary treatment and setting the expectation that one has about a 50-50 chance of needing a secondary treatment. These roughly 50% of men who have biochemical failure within 4 years are likely to need salvage radiation therapy. Historically, we've seen that rates of adjuvant or salvage radiation is low. In an effort to increase those, Music is collaborating with MROC, Michigan Radiation Oncology Quality Consortium. In Michigan, we have a goal of treatment with salvage radiation after biochemical recurrence. The target is that 45% of these men would proceed to salvage radiation when PSA reaches 0.2. VBR stands for value-based reimbursement. Music provides payments for quality patient care when target metrics are met. The rationale behind this is that the lower the pre-therapy PSA is, the lower the success of the salvage radiation will be. It's been previously shown that the PSA prior to salvage radiation therapy is one of the most predictive factors of long-term oncologic outcomes. As PSA rises above 0.5 to 1, 10-year biochemical recurrence nearly doubles, as does the presence of metastasis. Beyond a pre-treatment PSA of 1, men often have metastatic cancer already. So now we'll switch gears and talk more about quality of life and functional outcomes. Patient-reported outcomes are collected in participating music practices. The questionnaires are submitted by patients at a baseline and then at 3, 6, 12, and 24 months following prostatectomy. These include specific questions about the presence of lower urinary tract symptoms and sexual function from the validated EPIC 26 questionnaire. We have a goal of greater than 75% of men completing the questionnaires. Social continence goals are set at 75% at 3 months and 90% at 6 months. More than 120 urologists and 31 practices across the state participate in PRO. This has yielded greater than 8,500 patients enrolled in PRO, whose data has been captured for improvement of quality in terms of functional outcomes. Rates of nerve sparing vary by risk category in music. You can see that low and intermediate risk patients are more likely to get bilateral nerve sparing. When it comes to high risk patients, only about 40% of those men are getting bilateral nerve spare. More patients are getting unilateral nerve sparing in this group compared to the other two, and more than 40% are getting no nerve sparing at all. Dr. Peabody will later be sharing considerations around nerve sparing in high risk patients. Social continence is defined as 0 to 1 pad use per day. Patient-reported outcomes at 3 months are shown on the left side of the screen, and 6-month data is shown on the right. Social continence rates range between 60 to 70% in all 3 groups at 3 months. By 6 months, the rate increases to 80 to 85%, And the small gap between the low to intermediate risk and high-risk patients even decreases further the longer the recovery time. These patient-reported outcomes show that high-risk patients are not at significantly greater risk of poor continence following prostatectomy than low or intermediate risk patients. The same pattern does not hold up for post-prostatectomy erectile dysfunction. Here, good sexual function is defined as the ability to achieve erections firm enough for intercourse. The patients here are those who are noted to have good function at their baseline prior to surgery. 12-month patient-reported outcomes are on the left side of the screen, and 24 months are on the right side of the screen. Note that the y-axis only goes to 45. Overall, sexual function following radical prostatectomy across all risk categories is poor. At 12 months, 25 to 30% of patients with lower intermediate risk cancer have good sexual function, but only 15% of high-risk patients do. Then at 24 months, there's mild improvement, but still high-risk patients are achieving good sexual function at a much lower rate of about 20% compared to 30 to 40%. So variability is high amongst music practices for primary treatment of high-risk prostate cancer. This speaks to the fact that neither surgery nor radiation has been shown to be clearly superior primary treatment. The conversation for shared decision-making can be complex and nuanced. The music database is unique in that we're able to see outcomes among surgery patients in a real-world setting. This data is important for counseling. Men with high-risk cancer are seen to have an increased rate of locally advanced disease, positive margins, and biochemical recurrence following prostatectomy compared to low and intermediate risk patients. At 4 years, 50% of surgical patients will have biochemical failure. This increases the need for secondary treatment and the risks and quality of life changes that come along with radiation or ADT. In terms of functional outcomes, we've seen that social continence is similar between high and low to intermediate risk patients, but erectile dysfunction is significantly worse amongst high-risk patients. In part, this is related to the differences in nerve sparing. Next, we'll be hearing from Dr. Peabody and Dr. Dass on their respective modes of treatment and special considerations in high-risk patients. Dr. Peabody will first tell us more about the surgical side of the story. Thank you.
Thank you, Dr. Semerjian. I'm going to be speaking to you today about surgery for high-risk prostate cancer. As a background, the incidence of high-risk disease is increasing. The U.S. Preventive Services Task Force in 2012 recommended against prostate cancer screening. And since that time, we've seen a decline in the number of cases of prostate cancer, but an increase in the number of higher risk cancers. This is thought possibly to be due to the fact that we're picking cases up later since we're not screening for them. There's been a shift to a diagnosis of more cases with metastatic disease, and also an increase in the number of cases that we are operating on with high-risk disease. This shows an increase in the risk of Gleason 9 cancers and an increase in the rate of positive lymph nodes. The NCCN guidelines are shown here. These are familiar to most of us, but it does demonstrate that there's a role both for radiation therapy with hormone therapy that Dr. Dass will be talking to us about a little bit later in the program, as well as radical prostatectomy with pelvic lymph node dissection, occasionally then needing additional treatment, either androgen deprivation therapy or external beam radiation therapy and androgen deprivation therapy if adverse pathologic features are seen. Patient selection is critical, and I don't think there's a one-size-fits-all way to approach this. Certainly looking at the number of cores of high-risk disease, whether the disease is bilateral, whether it's at the apex or at the base, can be important. Shown to the right of the slide here is a graphic demonstrating the several different classifications for high-risk disease, the NCC and the DMICO EAU. There's also a categorization for very high-risk disease, which includes increased amounts of pattern 5, T3 or T4, and more biopsies with Gleason 8 through 10 disease. Use of nomograms can help define preoperatively the risk of disease outside of the prostate adverse features. The MSKCC nomogram is one that we've used for a long time. Music has developed one. It's available at the Ask Music site. In looking at these two nomograms, it seems that the MSKCC indicates a higher risk of adverse disease than the music one does, which was the one that was developed with our patients. So I think it's a useful one to look at, and the website is there. Whether there's a high likelihood of these adverse pathologic features or not, whether that should impact your decision to proceed with surgery, I think can be a decision made individually by surgeons. The challenges with high-risk disease are the same as the challenges for any prostate cancer surgery, only more so. The ability to provide long-term cure, the advisability and ability of performing nerve sparing, preservation of functional outcomes, and the need for multimodal therapy. Imaging is having an increasing role in the evaluation preoperatively for patients with high-risk disease. MRI has been shown to be useful for predicting the likelihood of extracapsular disease. Most of the nomograms are not including yet the use of MRI, but studies have shown that it may change the operative approach for both nerve sparing and the extent of pelvic lymph node dissection. I think in the future, PSMA PET CT is going to have a big role. This is information from a paper that was published last year comparing bone scan and CT to the PSMA PET scan, indicating an increase in accuracy. And I think going forward, probably some combination of PET CT and MRI, once this PSMA scan is more widely available, will be what we'll be using. This is data from a paper that was published during COVID, looking at whether delay in surgery portended a worse pathologic outcome. A similar paper was published by Dr. Scher and colleagues using music data, but this is using the NCDB database from 2006 to 2016, looking at the likelihood of adverse pathologic features in patients who had radical prostatectomy, who had high-risk disease beforehand, using the NCCN guideline definition. You can see that about half of patients had PT3 or PT4 disease, 10% had positive lymph nodes, and about a third had positive surgical margins. Interestingly, in the paper, delay up to 180 days didn't seem to make a difference. This shows the oncologic outcomes looking at cancer-specific survival, shown in this red box, and biochemical free survival in the next box. About 75 to 90% of patients were alive at 10 years with biochemical recurrence in about half of them. A paper written by Dr. Firas Abdullah and colleagues from Henry Ford and the San Rafael University in Milan looked at a combination of our databases with patients who had high-risk disease and found that functional recovery was associated with age, year of surgery, and that preoperative shim score, nerve sparing, the extent of T3 or T4 disease, and surgical margins were all associated with sexual function recovery. About 90% of patients were able over 3 years to recover urinary function measured as 0 to 1 pad. And of those patients who were preoperatively sexually active, between a half and 2/3 were able to maintain potency. This is data from the CAESAR trial, which showed that for high-risk patients, this is for surgery shown in the right and red line here, and radiation therapy. Results for sexual function at 3 years were similar, with similar data here shown for urinary continence outcomes. The extent of pelvic lymph node dissection is another point of discussion. You can see here 3 different templates for pelvic lymph node dissection. The one in the center, which includes some of the obturator and internal iliac lymph nodes, as well as the external iliac lymph nodes, is the one that is recommended. There are a couple of papers that have looked at the impact of lymph node dissection on oncologic outcomes. This is a paper from 4 centers in Europe that used the Briganti nomogram predicting a 5% risk of lymph node involvement. And it looked at doing a lymph node dissection or not doing a lymph node dissection. In the patients who had a lymph node dissection, 14 lymph nodes were removed. The biochemical recurrence rate, metastasis-free rate, and cancer-specific mortality rates were all pretty similar, whether or not a lymph node dissection was done, indicating that pelvic lymph node dissection did not improve these outcomes. There's a similar paper just published by Memorial Sloan Kettering looking at a limited versus extended lymph node dissection, which found similar findings with no significant difference in biochemical free recurrence at 3 years. The limited dissection had 12 lymph nodes removed as a mean, and the extended 14 lymph nodes. So there wasn't a big difference between the two. But again, showing that the extended lymph node dissection may not be that important. I wanted to show a couple of videos, and these are from the music video library, which we have talked about previously on some of these telecasts. This is available through the website here, musicurologyvideo.com. There are a number of different kinds of videos, and I'm going to show some video from a dissection of the prostate. And I think with prostatectomy, this is showing the posterior part of the dissection, which I think is important to get a good wide dissection. This can be approached sometimes initially before dropping the bladder or after dropping the bladder, as is done in this case. It's important to make sure you leave Denavius fascia posteriorly on the side that you're planning to do a wider dissection on for the high-risk disease. I think at the start of the case, making sure you open the endopelvic fascia widely to understand the anatomy in the periprostatic region is important. Dissection of the bladder neck can be wide with reconstruction, especially if there's a tumor at the base. This is now showing a dissection posteriorly, getting out laterally toward the bundle. We'll see a clip coming in here after the surgeon has prepared a space for the clip to be applied. There are several different techniques used in taking down the pedicle. I think any of them can be applicable here. Clips can certainly be used. Some people for a wider dissection will use a harmonic scalpel or some other kind of thermal energy. Bipolar energy can be also used. I think, though, it's in somebody who has a suspicion for extraprostatic disease, whether on MRI or predicted with the nomogram, it's important to try to take enough tissue to get a negative margin if you can. As the apex of the prostate is approached, we don't show that in this video. I think excellent vision is important, so it's important to control bleeding so you can really see, especially if an apical tumor is present. So I'll stop sometimes and suture the dorsal vein if I haven't controlled it initially to make sure that you can see and get around things well. We have used intraoperative frozen sections. These can be done by examining the prostate using the vision of the robot and then biopsy. It can also be done using a technique we use where we put a gel point and you can extract the prostate to examine it. I'm going to move to pelvic lymph node dissection, and we'll show a portion of this video. The lymph node dissection here starts lateral to the iliac artery and is developed sharply. I think it's important to make sure you identify the landmarks, which will be the obturator nerve. We'll see that in a little bit, and the vessels, both the external iliac artery and vein. Here, the surgeon's dissecting the bundle off of the external iliac artery. This could be done with a variety of instrumentation. You can do it with clips. You can do it with electrocautery, as being shown here. I think at this point, as a nice pedicle has been developed, the surgeon will come in with a clip. The use of clips probably does decrease somewhat the rate of lymphoceles. Most of us, I think, use electrocautery to divide the proximal and distal portions of the lymph node packet. This now shows release off the artery, and then there'll be movement down to the vein as the next portion. Dissection can continue down below the nerve and onto the internal iliac artery, or the internal iliac vein and artery as well. So in terms of tips and tricks for the point of view of nerve sparing, I think it's possible to do that, especially in cases where the high-risk disease is on one side. In the music database, almost half of patients with high-risk disease had a form of nerve sparing. Bladder neck wider dissection is probably useful, especially if the biopsies of the MRI suggest bladder neck involvement. Reconstruction can be done through a variety of different means. Posterior dissection, I think it's important to do that well and widely to really release the bundles. Leaving fascia on the seminal vesicle and the posterior part of the prostate is also possible. Lymph node dissection, although the data doesn't support a more extended dissection, I think most of us will do that based on the guidelines. And until I think there's more solid evidence that it's not important, we won't do that. And using a gel point to extract the specimen is something that we have found useful as well. Thank you very much. Look forward to hearing from Dr. Dess, who will be talking about radiation therapy for high-risk prostate cancer.
Thank you, Dr. Peabody. So my name is Bob Dess. I'm a radiation oncologist here at the University of Michigan. I am also the co-lead of the prostate working group of MROC, the Radiation Oncology Quality Consortium here in Michigan. So thanks to Music for the opportunity to talk about high-risk prostate cancer today. And also thanks to the participants. I look forward to our live discussion. So I was asked to talk about radiation therapy for high-risk prostate cancer today. And as I put these slides together, I realized it's as much about multidisciplinary care and high-quality care across urology and radiation oncology. And so you'll see that as a big component of my talk today. So I'd like to first talk a bit about treatment considerations. I think these are touched on by Dr. Peabody as well. Highlight a few of the recent music practice patterns. And then the bulk of the talk is going to be about advances in radiation oncology, both in the post-prostatectomy setting, as well as that for intact prostate cancer. So a bit about treatment considerations. I don't view this forum as a debate of radiation therapy versus radical prostatectomy for high-risk prostate cancer. I think we'd all acknowledge that there's no randomized comparisons in this setting. It is my belief that overall survival and cancer-specific survival are likely to be the same, especially if those modalities are given appropriately. Both are effective, both the prostate cancer has a long natural history, as well as we all know that there's competing risks of mortality for these men. What I do think is important, and I think is the foundation of our good relationship with urology at Michigan, is a multidisciplinary discussion. We tend to be patient and family-centered and an understanding of the patient's preferences, and a good understanding of baseline urinary, bowel, and sexual function, and a good consultation and appropriate consultation about side effects and quality of life post-treatment. And I think the real opportunity for music and MROC is to make sure that there's quality when the primary treatment is delivered, whether that be with surgery or radiation therapy. So a bit about the music practice patterns. We can see in the red line that radical prostatectomy is the most common definitive treatment modality for these men. I do note that in 2020, there was an increase in hormone therapy monotherapy in the yellow line, and that was at the expense of decrease of surgery and radiation therapy. So a bit about hormone therapy alone. The guidelines are clear here that hormone therapy, monotherapy for the vast majority of men with high-risk prostate cancer should not be used, with the exception of those that cannot tolerate primary treatment or have a life expectancy less than 5 years. Otherwise, definitive treatment is appropriate. You can see here as an older SPCG7 study that clearly the addition of radiation, for example, to hormone therapy has a dramatic improvement in overall survival. So my hope is that this is just an artifact of COVID, that many of our guidelines in the last year suggested that you can use hormone therapy as a bridge while the operating rooms get back to full capacity, or it becomes safer to come to daily radiation treatments. But I think it's important for all of us to recognize that these ensure these men ultimately get a discussion of a definitive treatment. So on to post-prostatectomy, those patients who undergo radical prostatectomy, seen here in the red line. There's been advances that I'd like to discuss in this setting over the last year that I think very much inform what the right thing is to do for these patients. I'd like to talk about adjuvant versus early salvage radiation, talk a bit about rates of salvage radiation. This has been an important focus of the music group. The role of hormone therapy in salvage radiation therapy, and the potential emerging role of molecular imaging in this setting. So most men, I argue, do not need adjuvant radiation therapy. We now have the large artistic meta-analysis that was published in the past year that took nearly 2,000 men randomized across 3 international trials, and individual patient-level data that was pre-planned analysis with a harmonized event-free survival endpoint that include PSA progression, clinical progression, new lines of therapy, death from prostate cancer. And you can see on the left here that favors adjuvant radiation therapy. On the right favors early salvage radiation therapy, and no clear benefit in these men with the addition of adjuvant radiation therapy. Now, there's some comments that men with multiple high-risk factors, your T3, high Gleason score, positive margins, were underrepresented on this trial. But even in those men, there was no clear evidence of a treatment effect interaction. And so for the large most amount of men, I do not think need adjuvant radiation therapy. In practice, less than 10% were receiving adjuvant radiation therapy anyway. And so some can argue whether this was practice changing data or that practice had already changed. But importantly, in the early salvage arm, 80% of those that recurred actually received salvage radiation at a median PSA of 0.2. And so why is that so important? Well, for one, we know that salvage rates vary and are quite low. So this is data from the Music Consortium that showed significant heterogeneity in the use of salvage radiation across our state, from a low of less than 10% to a high of 70%. And clinical factors alone did not explain this heterogeneity. And importantly, certainly the median and even the highest quartile did not approach the rates that were delivered on the clinical trial. So in practice, wait and see approach can equate to wait too long. And why does this matter? Well, number one, pre-salvage PSA levels, the level at which you deliver salvage radiation, is highly prognostic for outcomes. You can see here from our work from our group in multi-institutional setting, as well as groups from Dr. Tendolkar, that show even small changes going from 0.2 to 0.3 to 0.5 to above 1, the cumulative incidence of distal metastasis at risk substantially increase at the level of baseline PSA. Moreover, the higher the PSA when we see them for salvage radiation, the more likely we are to recommend hormone therapy. So we know, or many of us know, about the historical 9601 trial, which was salvage radiation, randomized plus or minus the addition of hormone therapy, that being high-dose bicalutamide. And the overall trial population, which include PSAs from 0.2 all the way up to 4, is that hormone therapy improved survival in this setting. What we have done is reanalyze this trial and looked at, is that benefit uniform? Do all men benefit from hormone therapy delivered in the salvage setting alongside radiation? And the benefit is different. So those who receiving late radiation therapy, I'm showing here by the stratification variable of a PSA of 1.5, but above about 0.7, 0.8, 0.9, there's a clear benefit of increasing survival with the addition of hormone therapy. For those who are receiving early salvage radiation, for PSAs that are lower, below 0.6, 0.5, 0.3, there's not a survival benefit on this trial with hormone therapy. And in fact, there isn't a large signal that there's a benefit for improving distant metastasis. Can genomic classifiers help? Again, in a secondary analysis of RTOG 9601, Dr. Feng et al. Looked at a genomic classifier of all the men on 9601 and were able to characterize them into low, intermediate, and high-risk groups. And they looked at the benefit of addition of hormone therapy by those risk groups. There wasn't evidence of treatment effect interaction as there was by the PSA level, but clearly the absolute magnitude of benefit with the addition of hormone therapy increases, i.e., we're more likely to give it if your baseline risk is higher. For those with low risk genomic scores, perhaps they don't see as much benefit with the addition of hormone therapy. Finally, can molecular imaging help? So this is a phase 2-3 study from the group at Emory that looked at what imaging we use to define our target volume in the post-prostatectomy setting for men who have recurred with a PSA after radical prostatectomy. One group used conventional imaging, the other randomized arm used, in this case, flucyclovine PET. The radiation field changed in over 30% of the cases. And you can see the increase in event-free survival in the group randomized to the flucyclovine PET group. Now, larger trials will be needed with bigger sample size to see the effects on distant metastasis and survival. This is a promising way to approach salvage radiation therapy. Now let's transition over to intact disease. A few things that I'd like to highlight here is the recent advances in hormone therapy duration, hypofractionation, how many fractions we deliver of radiation therapy, whether we can treat the dominant tumor as identified on MRI with a higher radiation dose, and what is the role of pelvic lymph node radiation, a long-standing area of debate since RTOG 9413, nearly 3 decades ago. For number one, nothing like summarizing 4 decades of research and hundreds of $1 million of randomized clinical trials on one slide, but I'm going to do it anyway. For the first 20 years, we spent nearly 2 decades and 2,000 patients understanding that some hormone therapy added to no hormone therapy when delivered with radiation improves outcomes, ranging from 4 to 36 to an indefinite length of hormone therapy. We spent the intervening 20 years with nearly 3,000 men demonstrating that longer courses of hormone therapy improved outcomes compared to shorter courses. 2 to 3 years were roughly those trials. What about something in between? And that's where the recent data has pointed us to something that may be intermediate to long-term duration of hormone therapy. So first, the TROG radar trial demonstrated that prostate cancer-specific mortality, 18 months, was better than 6 months when delivered to men, with 2/3 of the men on this trial had high-risk prostate cancer. On the flip side, though not formally designed as a non-inferiority trial, the Canadians, the PCS4 trial demonstrated that 36 months was not clearly superior to 18 months. And 36 months was associated with longer times to recovery of testosterone and decreases in function in sexual function. So collectively, is it possible that 18 months is just right for many men with high-risk prostate cancer? Hypofractionation. I like this figure in Nature Reviews Urology from about 5 years ago that shows that we used to do radiation for as much as 8 to 9 weeks of daily radiation treatments. We have the transition to what we call moderate hypofractionation, or 20 to 28 treatments, typically in the United States. and extreme hypofractionation, or SBRT, that's as short as 5 treatments. And the guidelines here are clear, endorsed by ASTRO and ASCO and AUA, that particularly if you're not treating the pelvic lymph nodes, that moderate hypofractionation is appropriate across all risk groups. And there are ongoing studies, the PACE-C being one of them in Europe, that is testing the role of more shorter courses and as short as 5 treatments compared to moderate hypofractionation. What about focal boost? So there was a trial named the FLAME trial that came out earlier this year that looked at radiation therapy to the entire prostate gland, and then looked at criteria similar to that from the PIRAD scoring system and increased the dose to that area. And it was a randomized trial, over 500 men, predominantly treated with long-term hormone therapy, and biologic disease-free survival at a 5-year early endpoint was very promising, over 90%. Survival, as to date, is similar. And what about the role of pelvic radiation? This is a trial out of a single center that's randomized, the single center in India. 80% of these men notably had actually PET staging at baseline and were negative for lymph node disease. And the randomization, about 200 patients in total, to pelvic radiation versus prostate alone. There was striking difference in terms of biochemical-free survival, again, over 90%, with the role of the addition of pelvic radiation. Now, again, survival was similar between both groups, and clearly we're not powered for that outcome with 100 men in each arm. But it does show the ongoing question of whether we should be adding hormonal therapy or pelvic radiation to prostate-only radiation. In summary, I think music provides an incredible vehicle for change. We don't know what to focus on unless we understand how people are treating. We don't understand areas of heterogeneity unless we understand practice patterns across the state. And I look forward to our continued partnership with MEMROC, because many men, as we can see by practice patterns, receive both surgery and radiation for high-risk prostate cancer. There are concerning trends with androgen deprivation monotherapy. My hope is this is all due to COVID, but it'll be something to keep an eye on. In the post-prostatectomy setting, it's very likely that salvage radiation, early salvage radiation, has similar outcomes to adjuvant radiation, and that spares upwards of 50% of men needing any radiation therapy at all. But we do need to optimize early salvage radiation and better determine the role of hormone therapy, PET imaging, and genomics in this setting. And then finally, in intact disease, I believe that we're getting more efficient, delivering courses over a shorter period of time with potentially a bit shorter courses of hormone therapy. And the role of focal tumor boost and lymph node treatment approaches are promising, but do need further validation in larger scale trials. So thank you. And I believe now we're going to go on to an open discussion with our participants.
All right, well, thank you all very much. Dr. Des, Dr. Peabody, really enjoyed those talks, very informative and really helpful to those of us who are on the ground level and counseling our patients which way to go with this. So we're gonna start with a case. The patient is, sorry, let me this up. So the patient's a 68-year-old male. He has a PSA of 28 and he underwent a uronav biopsy. On the MRI, he had an area at the right apex peripheral zone that looked to be PIRADS 5 with some extra capsular extension. In this area on the biopsy, there were 3 cores that were grade group 5. Across the rest of the prostate, there were multiple cores, other cores that were grade group 3 and 4. He had a total of 8 out of 16 cores, which were positive. Has a history of diabetes, hypertension, hyperlipidemia, and a BMI of 37. SHIM score of 18, IPSS is 13 out of 35. and his bone scan and CT scan, which were done for metastatic staging, were negative. Next slide. All right, so here's a picture of the MRI. You have the T2 image there on the right side of the screen that's showing on the right side of the prostate at the apex, the PIREDS 5 lesion, which has some extension into the neurovascular bundle. Okay, so we'll take it to our panel members. Please do remember to put your questions into the chat and hop in. We will answer those. Okay, so we're joined by Dr. George, Dr. Des, Dr. Peabody, and we have Dr. Brian Lane here as well, who have joined this. So we'll start with Dr. Peabody. How would you counsel this patient?
Well, he has very high-risk disease. And if you use some of the nomograms we have available to us, which I will typically do at some point in the discussion, his risk of non-organ confined disease, extracapsular extension is 80–85%, seminal vesicle involvement 30%. This is the music nomogram. Lymph node involvement only 10%. I would have thought it would be higher. The memorial nomograms have similar numbers, a little higher for lymph node involvement. But when you look at cancer-specific survival, it's actually not that bad according to the Memorial Sloan Kettering nomogram, where it's in the 90% range at 10 and 15 years. So I think he is a guy who could benefit from local treatment. And there's a discussion about whether we're going to cure him with surgery, since I would be talking to him about surgery initially. I think it's important to find out what's important to him too. You know, does he want to have surgery? Would he be more interested in radiation? We'd certainly have him meet with our radiation therapy colleagues in a multidisciplinary clinic. So I think that's the best way to get kind of a balanced discussion for things. So that would be my starting point. I wouldn't rule him out for surgery. I think his shim is 18 at 68 with an operation. The likelihood of him remaining potent is very low. And I would tell him that up front. Continence-wise, I think we do pretty well, though it may take a little bit longer if we do a wider dissection.
Okay. And this is for anyone who wants to answer this. Are there any patient-specific characteristics that would make you lean one way or the other? Dr. Lane?
Sure. For me, the patient characteristic on here would be urinary function, based on urinary function. I think at 68 and with what he's got going on, surgery plus minus radiation or ADT afterwards based on pathologic findings versus upfront ADT with external beam are both reasonable options for him. I basically say if you are miserable and your prostate's causing you a lot of trouble, taking it out can improve your quality of life, with some higher risk of incontinence versus radiation. If you don't have many urinary symptoms at all, that steers or helps me steer the patient more towards radiation versus surgery because we can only make things worse. So I feel that's probably, again, if you want to talk about one characteristic, that would be the one. And then in general, it would be what do I perceive to be the how well a patient will do with surgery. So again, a guy at 80, terrible idea because of incontinence. A guy at 68, I think both ways can go. And a guy who's 50, I'm nearly always advising prostatectomy with radiation as needed after versus upfront radiation.
Okay, we have a question from the crowd. So in a patient with clinical T2 DRE and a PSA of 28, is fusion biopsy necessary? Dr. George, you want to answer that one?
Yeah, so I actually don't, when the PSA is that high, I think the likelihood that you'll capture what the disease is going, with a standard biopsy is extremely high. Just your pretest probability of finding the cancer and the right cancer and risk stratifying them appropriately is going to be high. They're always going to be high risk, whatever cancer that you find. Even if you find Gleason 6, it's a high risk prostate cancer based on the PSA. That being said, it doesn't make sense for me to not do a fusion biopsy when you have at least a cognitive fusion or visual registration and directing some samples. Right apex, you can deliver a few calls in that area.
even if it's, you're not doing a formal software-based fusion. So I don't think you don't lose anything in that setting. You can only get additional information.
Okay.
And if I can piggyback a little bit on the case from Drs. Lane and Dr. Peabody, I fully agree with what's said. I almost think what the most important thing is to make sure that we're prepping this patient that they're almost certainly going to get multimodality therapy. And this, where many prostate cancers that we see do very, very well, some of them we don't even need to treat, or certainly don't need to treat right away. This is not one of those cases. And so I find sometimes that the patients, because of the heterogeneity of prostate cancer and because the messaging, some people think their disease risk is much different than it actually is. When I tend to see these patients with Dr. George or share them in a multi-D clinic, that seems to be the message that I want us both to deliver, is that if you're getting radiation therapy, I am recommending hormone therapy with it. And that hormone therapy is improving your survival. And that is an important part of, the treatment package. And as you think about the, incontinence risk versus the hot flashes and what things are important or not to you, same with surgery. I think we know now that 70, 80% of patients in this situation are going to have, they might not need adjuvant radiation, but they are likely to have a recurrence at some point. So having them understand that they can't go away and never check their PSA again, and that they may be meeting me again if they go down the surgery route. I don't know if that's how you guys feel, but my priority is just, let's set the stage that this is a real prostate cancer that we're dealing with. And then, make that less of a competition of surgery versus radiation, but more of, you need multiple things.
Yeah. And historically, I've actually leaned towards radiation in very high risk prostate cancer patients, because I feel like they're getting some sort of systemic therapy, given the likelihood that, the greater likelihood of micrometastatic disease. For example, I'm encouraged by seeing some of these, some of the results of the data that's presented, especially regarding continence. But, with the understanding that there is going to require multimodal therapy, is there a preferred primary modality then? Would something push you in the direction, say, hey, you're likely going to have multimodal treatment? Do you choose surgery up front, or do you choose radiation up front? And, understanding, yes, there are certain patient factors, and really the distinguishing features are going to be, not ADT, but sexual function is likely going to be a bit of a wash with the inclusion of ADT. Urinary function we see is reasonable with surgery, at least from a continence perspective. So it really is driven by bowel function potentially, and other symptoms of ADT. How do you reconcile that when you're discussing it with the patient?
I feel best. First of all, I think a lot of this is based, us framing the quality of life outcomes with both modalities and help people understand what's most important to them. I think that's where we have to start from. I will say I feel this is not one of those cases, but I feel best about the cases that are going to go down a surgical route are ones that may look organ confined with less extensive disease than this, that maybe we can get away with single modality treatment and avoid hormone therapy. That this case I don't think is going to happen. It may, but it's much less likely than a single core of Gleason 8 in an organ confined disease who may get away with surgery alone. And so I'm happy to hear what the surgeons have to say, but part of that is how much treatment are we signing the patient up for?
Exactly. All right, we have another question. What about patients with higher cardiac risk? What are you recommending for hormone therapy?
So,
go ahead.
Yes. Sorry, my short answer was going to be, if you're really trying to minimize ADT, then your options are upfront surgery, so you get a good grasp on whether there's lymph node involvement, whether you had T3 disease or not. And then you may avoid ADT altogether. If you're going to go with a radiation choice, I think it would be very helpful. I don't know if we've used the word decipher yet, but I think decipher is very helpful to figure out how much androgen a patient would likely benefit from, both from straight up low, intermediate, or high risk, or what the grid says.
Yeah, so I mean, that's, for example, the backbone of GU009, the new high-risk trial through Energy 2,500 patient randomized trial, and it's looking at genomic stratification of high-risk disease. So can we lessen the amount of ADT to 12 months, for example, in high-risk disease? And there's some data that maybe the type of GnRH antagonist versus agonist may have some cardiovascular effects, but I think that that's an area that is sort of open for debate. I think it's really trying to select the right patients and give the right duration. And if somebody has a cardiac event, maybe we need to think about continuing the hormone therapy.
The new oral agents too seem to have a lower cardiovascular risk, and I think that's an area that we don't really know anything about in terms of how that works with radiation therapy. I suspect, though, that's going to have to be studied at some point. The assumption will be that it's equivalent in terms of its hormone effect and its effect on the cancer.
Yeah.
If that has a lesser risk and somebody was opting for radiation therapy, I would certainly consider that. I've yet to prescribe it, but I suspect that that'll be coming in the future.
It's like the beauty of the drug is also the challenge: rapid onset, rapid offset. And do we, that helps with the side effects, but will that work the same with the oncologic effects? I think that's an open question.
Yep.
Yeah. So we have a couple more minutes left for questions if you want to submit them in the chat. Dr. Peabody and Dr. Lane, any surgical considerations for this patient? Do nerve sparing here? Would you do an extended lymph node dissection?
I'll go first, Brian, then you can go. I would not try to do a nerve sparing operation on this patient. I think he has extracapsular disease almost certainly based on the nomogram. The MRI suggests on one side the cancer is diffuse bilaterally. I don't think he's a good candidate for that. And even if you tried to do it, I think the results wouldn't be satisfactory. So I would not do that. In terms of the extended lymph node dissection, the data that I mentioned in my talk doesn't really support a benefit for that. I still would probably do it. I'm waiting to be more convinced by more data, I think, before I would abandon that. So that's my approach.
I would say in this specific case, I like MRI, I like biopsy findings to help guide nerve sparing, and I like patient preference and what their priorities are. So I would say clearly on the right side there with the clear EPE, you need to go wide and make a deliberate effort to do so. On the left side, I would cut closer to the edge of the prostate using the anatomy to guide me. If it looks sticky at all, I would go wider. I don't like going in on both sides and just deciding to go very wide off the bat. I'm concerned more about continence outcomes. So I'm also a believer in kind of incremental nerve sparing or doing what's safe to do. So I wouldn't cut extremely tight on the left side, but I would do basically a nerve sparing or a partial nerve sparing on that side would be my preoperative game plan. And with respect to lymph node dissection, again, I understand we all have different opinions about it, but my review of the recent Memorial Sloan Kettering randomized clinical trial that's saying limited is the same as extended also is limited gave them 13 lymph nodes and extended gave them 14 lymph nodes. I'm quite aware of other people's limited lymph node dissections and that they do not achieve 13 lymph nodes. So I would want to see a good lymph node dissection, whether you want to call that limited or extended. And for me, it tends to be a relatively extended lymph node dissection.
So we are just about out of time. Thank you all so much. I'm going to turn it over to you, Arvin.
Great. Thanks, Alice. And thanks to our panel members. This has been, I think, overall a really informative session. I feel like I really learned a lot. Today, we really see that there is a tremendous potential for PSMA PET, both in the primary staging space with its improved performance metrics over conventional imaging, but also in the detection, in detection in the setting of biochemical recurrence. Now, with recent FDA approval, we expect that this test will become widely available at your local hospital quite soon. But this can be an expensive test. In music, we have the opportunity to collect data to help us inform the best use of PSMA PET, similarly to what was done with CT and bone scan previously. And I think that it's something that we're going to have to consider as a group in the future to help answer some of these the questions that have arisen from in terms of clinical outcomes. Now, we've also seen today that the decision-making process for management of high-risk prostate cancer, it's complex. It's important to assess the patient's goals of care, but also to review the nuances and the specific outcomes for high-risk prostate cancer rather than grouping them into all prostate cancers. And we know that their outcomes are going to be poorer than that of low or intermediate risk cancers in most domains, both functional and oncologic, certainly. Finally, I'd like to thank our guest speakers and our panel members for joining us and sharing their expertise. This webinar was recorded, and we do plan to make it available for review. So if you joined late, or if there are portions that you missed or want to review again, we'll try to make it available either on the Music website or on the Music YouTube channel. And really a big thanks to our coordinating center team. That's Dr. Semerjian, Dr. Peabody, but most importantly, our prostate group, Stephanie Ferrante, Mahin Mirza, Corinne Labardi, Jichi, Anna Susan, everyone for really making this happen. It takes a tremendous amount of coordination for it to go as smoothly as it does. And thank you to the Russell Video team. Thank you again for joining us this evening. And we really look forward to seeing you in October.